Fundación Cana brings you the following article. Anti-tumor effects of cannabinoids, Quo Vadis, by Dr. Manuel Guzmán, Professor of Biochemistry and Molecular Biology at the Complutense University of Madrid and member of the Board of Directors of the International Association for Cannabinoid Medicines. The possible anti-tumor activity of cannabinoids is one of the aspects of current biomedical research on these molecules on which the media has focused most. For example, a review recently published in the journal Curious revealed that the news items appearing on social networks about the hypothetical curative power of cannabis in oncology patients have increased 10 times more quickly than those referring to standard anti-tumor therapies. Among the myriad alternative anti-tumor therapies, cannabis therapies are the most discussed, 23.5%, and in the vast majority of cases, reports are false. The authors of the paper estimated one true news item for every 118 published. Another clear reflection of the popularity of this topic is the large number of articles published on the Cana Foundation's website on the subject. Thus, several colleagues, Guillermo Velasco, Cristina Sanchez, Mariano García de Palau, Saoirse O'Sullivan, Mike Tagan, and apologies if I have forgotten anyone, together with myself have spent recent years disseminating our knowledge of the anti-tumor action of cannabinoids and their underlying mechanisms. In this article, I will try to update the status of the topic, focusing on raw clinical reality, patients, rather than on the often illusory preclinical research, mice. As I pointed out in 2 earlier articles, the bitter experience of recent decades shows us that for the diseases with the highest incidence and/or morbidity and mortality in our environment, such as cancer, cardiovascular diseases, and neurodegenerative diseases, the numerous therapeutic studies carried out in mice have been unsuccessful in practice in terms of their translation to patients. Yes, unfortunately, small laboratory mice are pathophysiologically much simpler, more robust animals than we are. For many years now, abundant scientific studies have been accumulating showing that THC and other cannabinoids exert anti-tumor effects in preclinical models of cancer, and that they do so by means of a very complex mechanism that, depending on the type of tumor, involves a combination of at least inhibition of cell proliferation, induction of cell death by the process of apoptosis, inhibition of tumoral angiogenesis, and inhibition of cell invasion and metastasis. Although these studies have involved the use of many different types of tumor cells, many of them have focused on glioblastoma cells. Moreover, the few clinical studies conducted to date with cannabinoids have only included patients with glioblastoma. Therefore, I will focus on that type of tumor. What is glioblastoma? Gliomas are traditionally defined as tumors of the nervous system that show the histological and ultrastructural characteristics of glia, i.e. the cells that accompany neurons in our nervous system. The WHO currently classifies gliomas according to various criteria, such as their cellular characteristics, type of glial cell, their degree of malignancy, from 1 the lowest to 4 the highest, and their molecular characteristics, occurrence of one or another genetic mutation. Among all gliomas, glioblastoma, until recently called glioblastoma multiforme or grade 4 astrocytoma, is the most frequently primary brain tumor in adults and one of the most aggressive cancers, along with, for example, grade 4 pancreatic adenocarcinoma. This dramatic behavior on the part of glioblastomas is mainly due to their high capacity for proliferation and invasion, their very high accumulation of multiple oncogenic mutations, and their astonishing ability to evade the anti-neoplastic effects of chemo and radiotherapy. Today, first-line treatment of glioblastoma, known as the STUP protocol, consists of 3 sequential stages. 1. Maximal surgical resection of the lesion. 2. Chemoradiotherapy with the anti-tumor drug temozolomide, 75 mg per square meter per day during the period of radiation administration. Adjuvant chemotherapy with temozolomide itself, 6 cycles of 150 to 200 mg per square meter per day for 5 out of 28 days. Unfortunately, this treatment regimen has very little effect on the course of the disease. Thus, median overall survival from the tumor diagnosis and after treatment with this protocol is 12 to 16 months. In the usual case of progression with recurrence after first-line treatment with the STUP protocol, overall survival is 3 to 9 months. Dozens of clinical trials have been conducted with various chemotherapeutic agents, as well as immunological or gene therapies, to try to improve on the STUP protocol, but successes have been very marginal. Therefore, it is absolutely necessary to develop new therapeutic interventions to improve the treatment of glioblastoma patients. Over the past few decades, the central focus of anti-tumor therapies has evolved from non-specific chemo and radiotherapies to personalized and molecularly targeted interventions. In the context of cannabinoids, as we know and have recalled before, the activation of a defined molecular target, the cannabinoid CB1 and CB2 receptors, by a family of selective compounds, THC and other agonists of these receptors, effectively and safely inhibits the growth of glioblastoma cells in mouse and rat models through fairly well-known mechanisms of action. Preclinical evidence also indicates that THC enhances the therapeutic efficacy of temozolomide and radiotherapy in mice. Moreover, one of the most desirable properties of any anti-tumor therapy is its selective action on malignant cells. In this regard, THC induces the apoptosis of glioblastoma cells without significantly affecting the survival of normal, non-malignant cells. However, there are still important gaps in our knowledge about the anti-tumor activity of cannabinoids that would require future preclinical research in order to optimize therapies that are translatable to the clinic. For example, we should increase our understanding of the molecular mechanisms of the anti-tumor action of cannabinoids, define the precise role of the endocannabinoid system in tumor generation, growth, and progression, design experimental cannabinoid-based therapies that offer the greatest efficacy and safety for the treatment of glioblastoma and other cancers, and identify molecular markers to predict the response to potential anti-tumor therapies with cannabinoids. So far, 3 small clinical trials have been conducted in glioblastoma patients to evaluate the potential anti-tumor effect of cannabinoids. In a Phase 1A pilot trial conducted in Spain, 9 patients with relapsed glioblastoma were treated intracranially with THC. Although no statistically relevant conclusions could be inferred due to the small size of the cohort, the treatment was shown to be safe and some patients appeared to respond to it in terms of lower tumor growth rate as determined by brain imaging techniques and lower expression of malignancy markers in tumor samples. Subsequently, in a randomized, double-blind, placebo-controlled Phase 1B trial organized by the British company GW Pharmaceuticals, a total of 21 patients, 12 in the Sativex group, 9 in the placebo group, with relapsed glioblastoma, were administered the oromucosal drug Sativex THC-CBD ratio 1:1, together with standard adjuvant temozolomide. It was concluded that Sativex had an acceptable safety and tolerability profile, with no apparent relevant drug interactions. Moreover, Sativex appeared to be effective as an adjunct to temozolomide since it improved the survival rate at 1 year, 83% Sativex versus 44% placebo, p equals 0.042, and at 2 years, 50% Sativex versus 22% placebo, p equals 0.134. Finally, in a randomized double-blind Phase 2 trial conducted in Australia, 2 standardized cannabis oils, THC-CBD ratio 1:1 or 4:1, were used orally in a total of 88 patients, 45 in the 1:1 ratio group, of whom 29 completed the study, 43 in the 4:1 ratio group, of whom 32 completed the study, with relapsed or inoperable high-grade gliomas. It was observed that the 1:1 ratio oil, but not the 4:1 ratio oil, improved some quality of life parameters such as physical, p equals 0.025, and functional, p equals 0.014 capacity, as well as sleep induction, p equals 0.009, without producing significant adverse effects. However, no beneficial effects on tumor progression were observed using a retrospective cohort of cases as a comparative group. In short, these 3 clinical trials carried out to date, if viewed in an optimistic light, would seem to indicate that yes, where there is smoke, there is fire. However, it is clear that more robust clinical trials on the subject are needed. In this regard, one hopes that the coming years will provide us with the valuable data from at least 2 clinical trials. A Phase 2 open-label trial to be conducted in Spain that will evaluate the effect of an oral THC-CBD preparation 1-to-1 ratio in first line, i.e. after surgery and concomitantly with standard temozolomide-based chemoradiotherapy in 30 patients with newly diagnosed glioblastoma. And a randomized, double-blind, placebo-controlled Phase 2 trial organized in the UK by the Brain Tumor Charity and GW Pharmaceuticals, which will study the effect of Sativex together with standard adjuvant temozolomide in 230 patients with relapsed glioblastoma. Hopefully these, and ideally other robust and well-designed trials, will clarify once and for all whether or not cannabinoids can really be incorporated into the very limited pharmacological arsenal available today for the treatment of glioblastoma. If so, it is likely that this could open the door to clinical trials in other types of cancers. This article was brought to you by Fundación Cana.